Telehealth services. Today we are having our first regular meeting since I think as far back as February. As chairman of the commission, I find that due to the state of emergency declared by the governor and as a result of the COVID-19 pandemic, and in accordance with the governor's executive order number 12 pursuant to executive order 2020-04 and its extensions, this public body is authorized to meet electronically. And please note that there's no physical location to observe and listen contemporaneously to this meeting, which was authorized pursuant to the governor's executive order. In accordance with the emergency order, I'm confirming that 1, we are providing public access to the meeting by telephone with additional access possible by video and other electronic means. We're utilizing Zoom for this electronic meeting, and all members of the committee and selected legislative staff have the ability to communicate contemporaneously in this meeting through this platform, and the public has access to contemporaneously watch and or listen to the meeting on Zoom or YouTube and via phone by following the directions and links provided in the general court website. We've provided public notice of the necessary information for accessing the meeting in the Senate calendar. We are providing a mechanism for the public to alert the public body during the meeting if there are problems with access. And if anyone has a problem, please email, and here comes the website, remotesenate@ledge.state.nh.us or call 603-271-6931. In the event the public is unable to access the meeting, will be adjourned and rescheduled. And please note that all votes taken during this meeting shall be done via roll call vote. Finally, let us start the meeting by taking a roll call of attendance. When each member states their presence, please also state where you are and if anyone else is in the room with you during the meeting, which is under the right to know law. I introduced myself previously. There is no one else in my home in Keene. And I'll now call our other members. Vice Chairman, Representative Bill Marsh.
Thank you, everyone. Can you hear me? I'm in Brookfield, in my office in Brookfield, and I am currently alone in the room, although my youngest daughter is elsewhere in the house.
Representative Gary Woods.
Good afternoon, everyone. I'm in Bow, in my house, in my study. I am alone.
Very good. Thank you. Nice to see you, Gary. Dr. Jonathan Ballard.
Hello, Jonathan Ballard. I work as the Chief Medical Officer of Department of Health and Human Services, and I am alone in my office in Concord.
And thank you. Nice to see you, John. Tyler Brandon.
Tyler Brandon, representing the New Hampshire Insurance Department, and I am alone in my office in Concord.
Thank you, Tyler. I got you on my other screen. I was trying to catch up with your teleconference from yesterday. Let's see, Ken Norton.
Good afternoon, everybody. Ken Norton from NAMI, New Hampshire, the National Alliance on Mental Illness, and I'm at the NAMI office in Concord. I'm alone in my office.
I'm sorry. I do need to recognize Mary Lowry, so I'm gonna try to do that. Mary, you can't, I know Mary is here. Forgot that besides being a presenter last time, she is a member of this commission. Let's see.
She's listed under attendees.
Yep.
And she has her hand raised.
Yes. There you go, Mary.
Thank you. Hello. Yes, I'm here. I am by myself in my office at Dartmouth Hitchcock in Lebanon, New Hampshire.
Thank you, Mary. And Joan Talk.
Good afternoon. Hi, that's Joan Tulk, and I'm home by myself in my home office.
Hi, Joan. Kim Moen. Not present. Rachel Chaddick.
Hi, Rachel Chaddock. I am here in Manchester at the VNA in my own office, all by myself.
Hi, Rachel. Thanks. Glad to have you today.
Yes.
Scott Westover, I think we have, is Dr. Omar Shah? Dr. Shah, are you replacing Mr. Westover?
Senator, I'm replacing Scott Westover.
Losing that. Who was that?
Sorry, it's David Donahue.
David Donahue. You're okay. Got it. That's see, there was a second. Sabrina Dunlap, who's joined us via phone.
Hi, everyone. This is Sabrina Dunlap. I'm Director of Government Relations at Anthem. And I'm sorry I'm not on screen. I'm in the car with one of my kids.
Great. Thank you, Sabrina, for making arrangements to join us. And Bill Ryder.
Hi, everyone. I'm Bill Ryder, and I'm the President and CEO of the Mental Health Center of Greater Manchester, joining the call from my office in Manchester, and I am alone.
And Dr. Shah. Dr. Shah, thank you.
Hi, my name is Omar, adolescent psychiatry fellow, registered liaison at New Hampshire Psychiatric Society. I'm currently driving from Vermont to New Hampshire, and I'm alone in my car.
Thank you, Dr. Shah. Good luck with your reception and in those territories. All right. Well, thank you all for making arrangements to join in the commission meeting today. The disruption or the inability of us to meet over the last several months is really got to do with the a number of committee meetings that were being held via Zoom, the number of licenses that were held by the Senate, and it just became impossible to, with the schedule that we were adhering to this year and the number of public hearings being held, just impossible to plan a couple weeks ahead and provide adequate notice to the public of our commission meeting. So that's why our extended hiatus. I anticipate that as in a going forward basis, that's not going to be the case. Last week, the House and the Senate needed to clear the legislation that originated in the other's chamber. So that having those deadlines having passed, I think we'll be able to meet with greater regularity. So as we come around to the last item on the agenda and you're thinking about what you do or don't want to do over the summer, think about when it makes the most sense for us to schedule another meeting, and we'll try to land on a more regular calendar once we pick that up. So one of the things that we had talked about relative to a regular calendar is to try to tap into some of the good resources that there are with this commission to understand how telehealth services were being embraced in different sectors. I want to thank Mary Lowry for leading off that presentation in February. Mary has an update that it's part of a reason that we might want to schedule a little bit in advance a next meeting. Think about that today, that to pick up on some of the items that Mary said would be new services that the Dartmouth Hitchcock Hospital would be originating. So we have one other presentation teed up, but we're going to now, and I think there are others of you who have presentations that we were going to come back to. So we'll pick that up again as we talk about future agendas. Today's agenda, though, we're going to highlight the mental health services and ask our member, Bill Ryder, to once again reintroduce himself. And Bill, I thank you for having prepared this presentation a couple of times.
Thank you, Senator, and thanks everyone. Let me see about sharing my screen here. Where did my document go? There we go.
Well done.
Hope people can see that a little bit, at least. Try to make it big. Slideshow from the beginning. That make it bigger. Okay. So unfortunately, I'm an analog man in a digital world, so it's having me follow Mary is going to be like a throwback to the Stone Age. So she set the bar really high, and when Jessica and the senator asked me to present next, I thought, oh man, this is the luck of the draw, so to speak. So bear with me, and thank you again, Senator. So I originally prepared this for our meeting back in April, but it got delayed, and so some of the data is only good through that time, although I did look at some April numbers, so I do have a slide at the end that I added to pick up on that. So what I hope to do today is talk to you about a research project that the Mental Health Center of Greater Manchester was involved in. That project happened during the pandemic, and so it's really the responses, of course, are pandemic related, but I think you'll find them interesting. And then I'll talk a little bit about the use of telemedicine by the 10 community mental health centers around the state at really now 5 different points of time, which will be from January in 2020, which was the pre-pandemic era, then May, which is full on when we were in the early part, then October, you might remember, October of 2020, I think it was just before we started to get into the fall surge. We were coming off the summer and things were pretty good. So that mid-pandemic era was a little bit of a calm before the storm in December, holiday time, and January, and then January, which you'll notice when we go over these numbers that affected by both weather and pandemic. And then we'll take a quick peek at numbers that I pulled from the 10 community mental health centers. Well, actually, I got pulled 9 of them. I'm still waiting for some data from one, but you'll get to see sort of how we fare in terms of in-person versus telehealth usage. And we've divided up the telehealth usage based on phone only or voice only and voice audio. Then some observations from our experience as a community mental health center and some conclusionary comments, and then any questions that you might have. And there's about 20 slides here. So we participated in this Vanguard group study. It was really a satisfaction study. The time frame was early pandemic, so May, June 2020. There were 15 sites in 13 states. You can see the states that are listed there, from California to Florida up here to New England. And the study involved both patients and providers. And those providers were counselors, nurse practitioners, physicians. And there were about 700 provider respondents and about 1,200, 1,300 patient responders. And so in terms of telephone only, it's interesting to note the bottom of the slide first, in that only 4% of the patients who responded didn't use the phone. So 96% of the people used the phone, and the provider was 95% used the phone for doing telemedicine. Again, remember, this is early on in the pandemic, so not a lot of people had been able to stand up the audio visual capability. With just phone only, the patients, only 4% of them reported a poor or very poor experience. So overwhelmingly, I think early on in the pandemic, the patients were really, from an experience point of view, just happy they could connect with their providers, that they didn't have to travel to do that, and that there was a safety net for them. The provider experience was less robust, although only 3% said it was poor or very poor. Double the number of providers, 28% versus 14%, thought it was only a fair experience. So providers were just a little bit less robust. Only 14 thought it was excellent versus 42% for the patients. And there again, I'm sure it was a lot of the effort on the part of the providers to do an adequate service for the patient, assess the patient adequately without, that in-person feel. So there again, where this is the phone or voice only experience right here. The audio video experience, that together, what's interesting about this is that out of the 1,200 clients, if you look at the bottom of the slide, that participated in the study, 59% or 753 did not use audio visual. So when this study was going on, the popular vehicle for telemedicine, as we call that broad term, telemedicine, was really voice only. And out of that, 44% of the 553 people who did have the experience of audio visual reported that the experience was excellent. So by and large, again, the experience for the patient of audio visual was excellent. It's again on the provider side, a little bit less robust. Only 21% of the 425 people who, clinicians who used the audio visual thought it was excellent. And there was more in the 49% and 26% respectively in the good to fair range. And again, you'll see in some of the comments that'll show on the next slide what some of the experiences were and how they were related by the providers. So this is the challenges. These are sort of the things that that both patients and providers found most challenging about telemedicine. The top, this is interesting, I think, for the patient, the biggest thing they missed was actually going to the clinic. And, to get out of the house and go to your provider, and, I think we underestimate this a lot. When people come in and they get greeted by the registration person and the secretary, and they get put into the room by the medical assistant, and then they get to talk to their provider, all these different things, all these different people they have contact with, it's important to them. And that was their number one thing that they found as a challenge. They didn't feel as connected to their clinician when they were just relating over the phone. There was concern that the clinician might miss something about their condition because they weren't present. And then, of course, there was the technical problems, but that ranked at more toward the bottom for the patients. On the flip side, for the provider, they said their biggest challenge was the patient having trouble with the technology. And I know in the beginning, there was a lot of fumbling around at the beginning of appointments with, trying the audio visual and then having that fail and then punting to the phone only. So there was that aspect. Like the patients, the providers, as their second biggest challenge, felt that feeling of disconnectedness. And again, this was an early on experience for people using telemedicine. They had, providers had other tech issues on their own end Providers trying to get their phone systems and their computer systems and their EMRs all to work together was frustrating for clinicians. And then, like patients, worried about missing things because of not being in person. On the positive side, the interesting thing is both patients and providers agreed that the flexibility in the schedule was terrific. It was often said that if a 10 o'clock appointment the patient was invited to a telemedicine visit at 10 o'clock and didn't come on, it was very common for the providers to keep calling. And even then, if they had a break later in the day, to keep calling that particular client back because it kept appearing on their schedule. And then they would eventually make a connection. Whereas face-to-face appointments, once the person doesn't show up, then it's usually, doesn't happen for the day. So telemedicine really provided great flexibility. Patients really liked the no travel. A lot of psychiatric patients rely on other people for travel, or they have, childcare issues and so on and so forth. So not having to travel to connect to your provider was considered to be a real positive for the patients. They felt less likely to miss appointments because a lot of the reminders now go through their phone. So you get reminded that Dr. Turnbull is waiting for you in the Doxy Me waiting room, and you go, oh, I forgot, and then you just hit the button on your phone and you're connected. Some patients felt more comfortable at home than in person. They're in the confines of their home, they're in their comfortable clothes, they're relaxed, they feel like it's very private, and therefore feel more comfortable. Providers, again, like the flexibility. They felt that appointments started in a more timely way, mostly, I think, because patients don't have to run the gauntlet of registration and all those other things that sometimes slow patients down getting to the provider. There was definitely a drop in no-shows. I know here at the Mental Health Center, our no-show rate pretty uniformly across the board dropped by about 8%. So more patients are actually getting the treatment that they signed up for, so to speak. The providers thought there was better patient engagement because in some areas of our work, we could actually have more contact with people for shorter durations of time, which seemed to support them through the pandemic in an encouraging way. And then lastly, so for providers, there was the safety element. You're not face-to-face with anybody who might be showing a range of emotions that could be a little scary when you're only 3.5 or 4 feet away from them. But over the telemedicine, it was a little bit easier to manage. So this is about the helpfulness of telemedicine. So the effectiveness of it in terms of treating the condition is what this slide gets at. And for the patients, you have about 15 to 16% who feel that the telemedicine visits were not as helpful as in-person visits. So that is that's a significant number, which is pause for considering in the future how one guarantees for the patient's experience that they don't get railroaded into a telemedicine visit when they really feel a need for an in-person visit. So I think providers need to be flexible in the future in order to ensure that proper access to in-person services is available. Providers, in terms of whether or not they predicted that they would use telemedicine after the pandemic, that you have about 35% of the providers who thought that 25% of their patients, up to 25%, they would continue on with telemedicine. About the same amount of providers thought that maybe up to 50% of their patients they could use telemedicine with. And then it sort of tapered off from there. So you could say that about 50 or 60% thought that a good portion, almost half of their patients could be seen via telemedicine post-pandemic. So this slide here is January of 2020. This was when we were all blissful and thinking that the coronavirus was a thing that wouldn't hit the borders of the United States. And as you can see by this whole green part of the circle, is those are in-person visits at community mental health centers. And about 1%, just a little less than 1% of all the services given in January of 2020 were done, less than 1% done by telemedicine. The rest were done by in-person visits. So this was a little bit of a detail about that 1%. So 4 of the 10 centers, 4 of the 10 community mental health centers were using telemedicine in January 2020, so prior to the pandemic. And that was Northern Human Services, Lakes Region Mental Health, the Mental Health Center of Greater Manchester, and Center for Life Management. With the 2 organizations of Northern Human Services and the Mental Health Center of Greater Manchester doing the greatest number of telemedicine visits, 308 for Northern, 286 for MHCGM. But out of the total number of events in those months, so for example, the Mental Health Center of Greater Manchester did 21,682 events, but only 286 were telemedicine visits. So you can see it was in place in 4 centers out of 10 centers prior to the pandemic. And of those centers, it was a very low use vehicle. And I know at the mental health center, it was used exclusively by medical staff, psychiatrists. So it was not used at all by clinicians or any other providers. So that kind of gives you a lay of the land going into the pandemic, which really hit in February, March. So now we jump up to May 2020. And by here you can see in the yellow and orange portions of the circle that roughly 70% of the services had gone to either phone, which is the orange, or the yellow is video and voice as telemedicine. So we were more phone dependent in May of 2020, which was indicative of the fact that that was the easiest thing to convert to right off the bat. And as a group of mental health centers, we dropped to 31% in-person visits. So then we jump ahead to October. And in October, the virus conditions in New Hampshire were at a low level. And we jumped up from 31% in person to 52%. So a 20% increase in person. And you can see on the phone and the voice, the yellow is the voice and video, and the orange is the voice or phone only. Those numbers came a little closer together, but still the phone predominant. So then we jump to January, and you can see in January the in-person visits dropped almost 9%, I'm sorry, 11%. We went from 52 to 41. So a couple things about why that occurred. One is, you might recall that in January the virus got worse, so we had substantial transmission troubles in the state with the virus. And 2, you have weather. And we, many clients opted and providers opted for more visits. But you notice how close these 2 numbers are. We're almost at 30% each for video and audio and phone only. So this is a slide that just shows all of those slides together. You can see the gray here in January of 2020, that's all the in face-to-face. And then by May, you can see that you have the phone, which is the blue, as the predominant modality of connection. And then in October, you have more face-to-face. And then in January, it fluctuated down. So you can see there was a great deal of adjustment by the community mental health centers and the patients and families that go to the community mental health centers and how they accessed services. So this is April. So when I put this slide together, I got this far, and then I thought you might want to know, well, what happened after January of 21? And so this is April of 2021. And we've jumped up to 49% in person. Remember, the zenith in the past 18 months or 15 months has been 52% face-to-face, which was in October. We're up to 49% face-to-face right now. And as you can see, the voice and video now exceeds the phone only by 3%. So people are getting more competent on using these platforms. These platforms are becoming more reliable. It's a coaching situation for the both the staff to get facile and agile with the equipment, but it's also a big part of connecting with the patients and understanding what their capabilities are and giving them the proper instructions for how to connect to the voice and video. So we've done a lot of that where we share information to give them instruction, or we have somebody walk them through. We've actually had support staff do some practice sessions with people. But, you know, there's people who don't know a lot about, you know, terms like browsers and bandwidth and all these kinds of things. So there's a lot of teaching that needs to be done. Organizations need to be prepared to do that. So here are some observations to just kind of summarize. There's no doubt that flexibility was a big plus when using and accessing services through telemedicine. As I said earlier, because you can now access clients more frequently, but for shorter duration, which can be a very powerful tool in some clinical situations with patients. I can say specifically for MHCGM that we never had a snow day this winter because now we have what we call remote days, where we go into total remote mode. And whereas in previous years, our service capacity on a bad snow day would drop by 90%. On our remote days this winter, we only lost about 10% of our appointments during those remote days. So think about that in terms of patient access to care. That's really phenomenal that you don't miss a step. And you actually, by doing that, you increase, without increasing staffing or increasing hours or anything, you've actually, through telemedicine, have increased the capacity of the service system, which I think is phenomenal. There was great flexibility for clinicians to work remotely, and it allowed for weekend work to be done. So during the pandemic, we had situations of our staff where they would have a family life in the pandemic world, and husband and wife are both working remotely, and there's children in the house that need supervision, and they would divide up the work week, and they would divide it up over 7 days. So we ended up with quite a number of clinicians who did work on the weekends that heretofore had not done work on the weekends. So it actually expanded our work hours for many patients. The home disruptions that occurred during the pandemic, specifically quarantining, people get caught up into quarantining, but also things like childcare. You have a sick kid at home or whatever it might be, they can continue to work on a day like that. Whereas before they would have to call and we would have to cancel patients. Telemedicine also has increased the work life for many who've contemplated retirement. That's exactly the reason why the Mental Health Center of Greater Manchester got into telemedicine in 2016, because we had psychiatrists who were retiring and going to be living part of the year outside of New Hampshire. And when we had a conversation about them continuing on with us on a part-time basis, whether they were in Florida or here, they said, I really want to continue to work. And if I can do that, that would be great. Well, it turned out to be terrific for them as a way of cutting back and going into sort of a soft retirement. But it was really great for the patients because they had been able to keep contact with staff psychiatrists that they had grown to trust over a period of many years. And in fact, we've had on the clinician front, the non-psychiatry front, we've had 2 clinicians who following the pandemic have moved to be closer to family because family is important out of state and yet continue to work here in New Hampshire. So we've been able to preserve the New Hampshire mental health workforce because of telemedicine. Both patients and providers feel that the telemedicine is as effective in most circumstances as in person. And we think that the telemedicine really allows an organization like ours to operate almost at full capacity all the time. And so the example here is that, we saw 400 more patients in fiscal year 20 than we did in fiscal year 19. And we provided 42,000 more service interventions, despite the fact that there was a pandemic for the last quarter of fiscal year 20. I think that's amazing. I would have never thought that was going to be possible. It's better for the environment. People don't travel as much. I don't know about all of you, but when I went to register my car, I realized I drove half as many miles this year as I did last in my car that I live in Concord and commute every day. So, I used to run around to all sorts of meetings, but all my meetings are although I was in the office most days, most of the meetings, of course, are Zoom. There's an advantage because no shows drop. Telemedicine helps you to make up for a scarce workforce, and there are guidelines to providing telemedicine services, and we access those through the APA, and really believe that it's a great intervention for fostering long-term recovery. So with that, that's all she wrote from me, and certainly happy to entertain any discussion that might come up as a result of this. Otherwise, I'll stop sharing my screen if I can figure out how to do that here.
Yeah. Thank you so much, Bill. And if you'll share those slides with me, I know that we'll find some way of making them available. I see Tyler Brandon has had your hand up. Should I recognize you, Tyler?
Sure, thanks. I just was going to ask about some of the observations. It did seem like both the patients and the providers mentioned that they felt less connected, but then there was the comment or the response about kind of increased patient engagement. And I'm going back to the value of the services that are provided when it's done virtually, and whether or not those are sort of different things, or I don't know, maybe impressions you have about it and potentially how it changed the value of the service when it was provided virtually. Any thoughts at all?
Yeah, I think that that for folks who felt less connected, a lot of it was people who had been used to coming in, and I think that some of the engagement issues with patients on the positive side really came from the patients who were able to access us during the pandemic and found that they could have more frequent, maybe shorter duration visits in order to kind of keep tabs on how they were feeling and how they were responding. But I think one of the things that I'm looking forward to is we're going to repeat, the Vanguard group is going to repeat the study. Because we believe, or there's a hypothesis that the value of telemedicine may change in the eyes of the patients and the providers when there's not the pressure of the pandemic. When you have the pandemic and it's it's kind of like if you're really cold and freezing outside and you walk into your house and it's 55 degrees, that feels great. But if you're in the house and it's 55 degrees all the time, you might feel like it's a little chilly. And so I think it's like the kind of thing where, once people aren't threatened by the fact that they don't want to leave their house because they're afraid of the virus, and the virus has gone away, it'll be interesting to see how the value of telemedicine shifts, if at all. My belief is it will shift a bit, but my belief is that that it's a really powerful tool that if patients and providers can find their stride in what interventions work best, using which vehicle or a combination of that will really go a long way in helping people stay connected to mental health treatment and prospering from it.
Bill, one of the places I was hoping you'd we'd be able to get to is some people have been critical of audio only consultations. That even there's lower, fewer cues to observe. And was that at all picked up more discreetly in this analysis, or is that something that maybe with some input you might be able to advise the Vanguard group to queue up in the future?
Yeah, I think that part of that is if we noticed on the slides that we as time went on, even in January of 2021, when the pandemic was pretty strong, that the amount of phone calls went down and the amount of the audio visual telemedicine went up. And I think that was in part provider and consumer driven. I had this thing that I did with the staff, which is kind of interesting. It was in the last week in March. I did 10 what I called gratitude sessions with our staff, and I scheduled all these Zoom meetings, including one I scheduled at midnight for the night staff. I scheduled one at 10 p.m., several at 6 and 7 at night, some early in the morning, all hours. And I got all sorts of staff who were interested in tuning in and having a conversation with me. And the staff really had surprised themselves. They said, a couple of them said, if you had told me, if there was no pandemic going on and you hired me and you said, I want you to do patient evaluations over the phone, I would have thought you were crazy. And there was no way that as a licensed clinician could I ever do a mental health assessment, an adequate one, over the phone. There's just no way that could be done. Well, then the pandemic comes, and then that's the only way. So that you have a licensed clinician who wants to give care, and you have a patient who is in need of care in a big way. And you say the only vehicle you have to do that is a phone. They figure out how to make it work. They don't figure out probably how to make it work to the extent that it would be in person, but they made it work so that some suffering was relieved, and potentially some very untoward events avoided because of that phone connection. So there it is again. When the pandemic is gone, it's going to be, I feel, really important if organizations are allowed by the laws and the rules that we figure out to be able to do this flexibly. It will be really important to figure out whether or not, patient A, you might be able to do something pretty good and get a good response telephonically, but patient B, it's definitely an in-person. And the voice video capability is a good intermediate step.
John?
Thank you, Senator. Bill, excellent presentation. Thank you so much. I had a question. What do you think that percentage is? It was March 18th of last year when Governor Sununu signed Emergency Order Number 8. One of the provisions was allowing audio only. And we weren't thinking which one's better, audio, video versus audio. We were thinking the option is audio versus no care.
Right.
And so we were looking at people going to the emergency department potentially for treating their COVID-19, but how could those persons get their symptoms treated, properly triaged, avoid further spread of the disease through audio only treatment, essentially, if that's all was present in rural communities because of broadband issues, or even in urban issues where I believe there's more people without access because of device access, internet access. And I think Representative Marsh can correct me, but I think this was part of the conversation when your bill 1623 was being discussed and passed, codified that as well. So my question, Bill Ryder, is what do you think that percentage is that's audio only versus no care?
Well, I would like to see the fact that I wouldn't want, I think what we've proven by this experiment that we were all thrown into is that easy, low bar access to care is preeminent. And I would think that if we could continue to do and be reimbursed for services done over the phone, that that for many people, whether that's 20%, 25%, will mean the difference between them not getting care or getting care. Because no one calls 668-4111, which is our phone number, because they're having a good day. And most of the people who call us months too late, and many call us only at the behest of others. And some would prefer not to be connected with us at all. And so anything that gets in the way of that will, in my view, only contributes to a potentially declining situation and more suffering for the patient. And so the fact that we can engage people over the phone and keep them connected and try to help them find a path to a better state of well-being is that's a powerful tool that I would hate to see get packed away for the next pandemic.
Thanks, Bill. One of the people on the attendee list today is Lindsay Courtney, who I know has a limited time. Lindsay's the director of the Office of Professional Licensure and Certification. And during the legislative session, I'm not trying to shift away from Bill's conversation, so hold your questions or jot them down so we can get to them. But one of the legislative issues this session was licensure of out-of-state providers, New Hampshire licensure. And I wanted to make sure that we covered it. Lindsay, you're recognized here. If you could take a second, if I've picked up on the right top issue that you think has affected licensed professionals, healthcare professionals in the state, great. If there are other issues that you think popped up during this session that relate to care providers in the state, feel free to drift afield.
Thank you, Senator, members of the commission. Lindsay Courtney, Executive Director, Office of Professional Licensure. I think you're exactly right, Senator, that the top issue that the agency faced and the boards faced during the pandemic was this sudden surge of license applications as a result of the COVID-19 pandemic and the virtually overnight shift to a telehealth platform. Fortunately, the state, I think, was very proactive in its approach in seeking emergency order number 15 that allowed the agency itself to just issue licenses without cost to those in another state who had a license in good standing. To date, as of April at least of 2021, the agency has issued 22,000 licenses. And actually 65% of physicians authorized to practice in New Hampshire are doing so on an emergency license, and 63% of psychologists licensed in New Hampshire are doing so on an emergency license. I can tell you that when we first started licensing individuals, we didn't have a plan in place. So I was personally doing it manually from my kitchen table until about midnight. And it actually was interesting because I think we were expecting this surge of applications from physicians and nurses. You know, we're gearing up to really deal with the surge of COVID-19 at facilities. But what I saw and what I observed was really interesting in that it was a surge of mental health providers who were seeking licenses. And a lot of them actually live and reside in New Hampshire, but they were working across the border in Vermont or Massachusetts. And because their patients switched to a telehealth platform, the patients were now physically located in New Hampshire and needed a license in order to provide that continuity of care. We also saw, as colleges closed, universities closed, that there were, psychologists, mental health providers in other states who wanted to continue to provide those services to their patients as their as the students moved home. I think I would say probably 6 months into the pandemic, when we realized emergency licenses were not going away, that it then started to be utilized as a mechanism for obtaining a quick license while a permanent license application was pending. So we've been processing them in about 24 business hours, provided they're complete, and that, that's very different from some of the other licensing applications that require a little bit more information and require review by the board. So we do see people utilize the emergency licensing process to just get in the door and get a license quickly, which has actually been very positive, I think, for us in helping to meet New Hampshire's workforce obligations. So, eventually when the state of emergency ends, the agency plans to transition to a temporary licensing solution that we have existing statutory authority to do so under 310A to issue temp licenses based on the same criteria. And I think that'll really help bring in those out-of-state applicants. So that was some interesting feedback. Unfortunately, we don't really have much in terms of data, in terms of what people were doing by providing telemedicine or telehealth services. I just know from my own interactions with people that a lot of it was done via telehealth. And a good substantial number of those license applications were done in conjunction with the Department of Health and Human Services, because what we observed is that a lot of the enrolled Medicaid providers are based out of Massachusetts, and as they switched to a telehealth platform, they needed a license application. So we worked with the department to make sure that they were licensed so that they could be eligible for reimbursement. But Senator, in terms of the legislation that was pending this year, we had several, I would say 3 pieces of legislation regarding telehealth. And Senate Bill 57 is, may not be at the top of everybody's radar from a telehealth standpoint, but I do believe that's passed both chambers. And that would permit pharmacy techs and pharmacy interns to perform certain non-dispensing activities at a remote location. I believe this was requested by PillPack. So that would essentially allow non-dispensing activities to be performed remotely, such as drug utilization reviews, product verification tasks, claim adjudications, refill authorizations. I think Bill is absolutely right that people were forced to think differently and are now seeing the benefits of the remote work. The other pieces of legislation that we saw this year, HB 602, relative to reimbursements for telemedicine, I think that was alluded to earlier. That was retained in committee, Health and Human Services and Elderly Affairs at the House. That would really change, as you know, the reimbursement piece, both for Medicaid and insurance coverage, to make it so that that instead of providing, equal reimbursement for both in-person and telehealth visits, that telehealth visits cannot, the reimbursement for those cannot exceed in-person coverage. And it would also eliminate that audio only reimbursement for audio only services. I can tell you then, talking to the boards and providers, that the issue of audio only hasn't come up too frequently, but it does come up in terms of the standard of care. And so that's an interesting conversation that I think needs to continue to be had. If the choice is made between no care versus some care via an audio only platform. Obviously, that's more beneficial to the patient. But when we talk about the standard of care and the requirement that the standard of care be the same, which is our current statutory requirement, you still need to provide a minimum level of care. So I think that's a perspective that obviously will need to be taken into consideration if any changes are made regarding the audio only versus a requirement that there be audio and visual. And then lastly, there was Senate Bill 133, I think it's part 9, regarding the telemedicine provided by out-of-state psychologists. I can tell you that the gist of the bill is that that the board sought to create an additional licensing category to specifically only for telepsychology. The board and the agency were in disagreement about how to accomplish this objective. To be quite frank, the agency does not believe that additional license categories are needed in order to perform to provide telehealth services, that only a license is needed and we don't need to create additional licensing categories. The board felt that their existing application process was a little onerous and wanted to promote easy access to telehealth services and to allow those out of state to transition to licensure more easily. So I think the compromise that we settled on was to license all of those psychologists that currently have an emergency license with this new telepass license. So that actually was voted ought to pass out of committee. And I expect we'll be going to full house if it hasn't already done so. So that's kind of a summary of where we're at from a licensing standpoint. I'm happy to answer any questions. We were just floored by the numbers once we finally looked at the data. We have 229,000 active licenses in the state of New Hampshire, and nearly 10% of those are on an emergency license, which I think is really fascinating. But in any event, happy to answer any questions.
Great. John?
So Lindsay, I think one of the components of the remaining limitations for telehealth, once the state of emergency is over or the executive order number 8 and 15 are removed, will be that the prescribing of medication-assisted treatment for the treatment of substance use disorder, such as methadone or buprenorphine, will be it will still be allowed in certain situations, the doorways, I think jails and some other locations, but currently under the pandemic state of emergency, the initiation of those medications is currently happening without a face-to-face in-person visit, but that will be going away. Is there anything thoughts on that? Is anything coming up with the licensing boards or any considerations?
So we don't have anything currently in the works that I think would get around that issue. I know when this initially came up, we were essentially mirroring the federal government requirements. And I think that we need to take a look and see whether those have changed, because maybe there's an argument to be made that even if we're not operating on a state of emergency, that we can look at those federal guidelines. I do think it's something that we need to explore for probably next legislative session, because again, we are forced to operate in this environment, this less than ideal environment. But I think some of the positives that have come about are that maybe, it's not, well, there are things that can go wrong, right? We need to look at whether or not the risks outweigh the benefits. And I think that's some interesting data and some anecdotes that we were able to receive last year. And going into this next legislative session, need to consider whether or not we make any changes.
So that's something for us to put on our future discussion list. Dr. Ballard, do you agree that we should?
I agree that further conversation should be had on that topic.
Regarding medical assisted treatment for mental health care and prescription services, and how comprehensive our current statute, by virtue of House Bill 1623 in the 2020 session, what kind of delivery is cut out between the executive order and the, or the emergency order and the current statute, right? That would be what we need to hone in on. Because we certainly did anticipate a lot of clinical locations being able to be a connecting site for MAT services. But perhaps they go beyond just being, maybe there are other kind of emergency calls coming in, right, that are, that require MAT services to be delivered, and the provision of scripts beyond a physical location. That's what we may need to consider.
Yes, I believe it's permitted to be prescribed in emergency departments, doorways, and county jails, but there's limitations. It cannot be prescribed other locations to rate without a face-to-face visit in person. And that would be something I know is happening now, and there are a lot of advocates out there that believe it can be happening safely, and I haven't honestly looked at the information or data, but I would like to look at that closer.
So while we're on that topic, I know we've got two representatives that are on that Health and Human Services Committee that where the bill is retained. So or perhaps that bill is an opportunity for us to discuss other needs than were originally addressed in that bill.
My understanding is that the committee is expecting one of the work products of this commission to be a recommendation as to what to do with that bill, because we anticipated that something would need to happen. So if we could have that in our time frame for early on, so that it could be brought back to the committee, that would probably be very helpful.
Yep. And so thinking about what we might do in sometime between today and September, committee probably would be taking up any kind of consideration of that bill sometime in September or October, right?
That would be my understanding. And I think that Dr. Ballard likely has some ideas as to how he would, how the department would like the language to end up, and certainly could bring some draft language to us, and we can use that as a starting point.
Perhaps. I think it may be helpful, Senator Khan as well, and Representative Marsh, if we could potentially think about who we can invite to our next meeting that has a lot of in-depth knowledge about this area. I see Courtney Tanner on the attendees list. I don't know if DH or if there's other providers in the state who may have a lot of knowledge that could get to provide some testimony to this commission.
That's a good idea, John. And you know, to those who are viewing our work, who I recognize quite a number of the names because you've been viewing the work of this commission previously. If you've heard that request from Dr. Ballard that we seek some folks that might have in-depth awareness of MAT services and what kinds of delivery is, what voids there might be in providing MAT services if we do not act post order, emergency order, that you'll offer us some suggestions shortly. And Bill and I can, Bill Marsh, Representative Marsh and I can get together and we can try and sort through that and talk with Dr. Ballard and see where.
I think Representative Wood should be part of that discussion.
Wood should be part of that discussion. Yep.
Yes, please.
I'd be happy to.
Thank you, Representatives. Okay. Further questions for Bill Ryder? Lindsay, thank you for joining us and filling us in there. That was good.
You're welcome. Happy to help anytime. Have a good one.
So seeing, let's see, Bill, I want, the other thing, Bill, is, was there an increase in total visits? Did you notice that? I mean, that's one of the other things that we sometimes hear about telehealth, that it's increasing the number of visits. But then the other side to that is, but the visits aren't taking quite as long because they're mostly check-ins. And anyway, I was wondering if there was any observation on total volume.
Yeah, the number of services that we provided in fiscal year 20, which of course ended last summer, was greater than in fiscal year 19, despite the fact that 3 months, solid 3 months, March through June of 20 was in the pandemic, and we're providing more services this year than in 21. I anticipate, based on what's come through, than in fiscal year 20. So I think we're able to, because we can deliver services flexibly, despite the fact that we have a terrible workforce shortage. I think we're able to optimize our workforce efficiency in connecting with patients, because we have the flexibility of 3 modalities: phone, audio, visual, and of course in person. And so I think that it creates certain levels of efficiency that create a better usage, a better utilization of the capacity of the organization.
Great. Oh, I see. Rachel, you.
Yes, I have one question, Bill. As I think about what you just said, I'm wondering, so definitely the telehealth visits, telemedicine visits you did allowed better use of resources and being able to do things. I'm wondering if part of the growth, though, could also just be an end result of having lived through a pandemic and some of those mental health issues that arise. Was there perhaps a greater demand for service just because of where we were psychologically trying to get through this?
Yes, yeah, no doubt. Our patient numbers are up. So, you know, the number of services per patient, I don't have that exact ratio, but obviously some of that is because of, you know, new patient demand. I think that what I feel like in the question is whether or not telemedicine makes it easy to overutilize medical services and potentially, you know, costing the system more and not getting effective care out of it. And I haven't seen any signs of that, but I do feel like it is something that we have to figure out how to ensure that that doesn't happen. And you know, there is the industrial medical complex that, you know, has to be fed and can be treacherous. And sometimes I have these moments where I realize that I'm a part of that, and I have to examine my own conscience about all of these things. And when I think about the individual who in their most vulnerable time is depending upon the mental health center, I want to make sure that we can get attached, but that we're using the right vehicles for connecting with our patients, and that's done in a way that's optimizing, you know, for their benefit, not our benefit. And I feel like you know, especially when the senators and representatives that in every day of their work, I think they're trying to balance how do we keep everyone's special interest in balance for the benefit of our citizens. And so that's a big thing that weighs in my mind when I hear a question like what the senator posed.
Thanks, Bill. Thanks for the questions. I see Dr. Ballard's going to need to leave, and he's provided us with some updates on Medicaid services for the last 6 months. John, can we tap you for a couple more minutes?
Sure thing. It won't take long to go through the couple of points that I gleaned from the data. So if I can share screen, I can go to the data. Okay. So this first one is simply Medicaid claims. You see in March, April 2020, essentially claims for telehealth went from near zero. It wasn't zero. It was actually about $70,000 over the course of the previous year of 2019. But on a month-to-month basis, it went up. Each of these lines, sorry, I don't have it labeled on the y-axis, is millions of dollars. So it went up to about $9 million and about 80,000 different claims in April, the height. And of course, as the summer went along, those claims went down, but they didn't go significantly down, only down by 20%. And then you see during the late fall and the winter surge of this past year and into this beginning of 2021, the claims went back up for telehealth. So they did mirror individuals' ability, the public health guidance of whether a person should of social distance when possible. So you do see that claims are still steady, at 64,000 claims there you see in February of this year. This data was captured beginning of last month, so with the 2 to 3 month lag in claims data, February 2021 is the most recent data I have for this. And if you want to look at the individual members in Medicaid, we look at the per member per month fee, the total charge that is reimbursements that are per beneficiary in the Medicaid program. It went from close to zero to the height of $47, but still between $35 and $40 today of the total amount of funds per member per month. When you think of the per member per month and the larger amount for all care, knowing that procedures, hospital care is the bigger expense, it's around $470 per beneficiary when you look at all the types of different categories in the Medicaid program, whether it's the children in the CHIP program or expanded Medicaid or traditional Medicaid. But when you further go into the data, you see, this is what I found interesting, is again, it's mental health care is where the majority of the funds went. Mental health care, number one, and then all other, regular types of telehealth visits, and then substance use was also a significant driver for persons receiving treatment for substance use disorders. But again, mental health was the largest cost to the Medicaid program for telehealth services. And lastly, I wanted to bring this one in, and this one's concerning to me. I wanted to dive into preventive health care. We had a lot of conversations, and we actually had to go back and I think issue some guidance around that emergency order number 8 around what was allowed for preventive health care. And we said preventive health care is allowed under the telehealth emergency order, even if all exam components could not be delivered in person, you could still do a preventive health visit. But despite that, at the height of the pandemic, we only had 511 preventive health visits, annual checkups that were delivered in May of 2020. And it's come down, which would be expected because, it's really hard to do a physical by telehealth, but there are elements of the preventive health checkup that can be done. What's really concerning is that, you know, overall, everybody was, we don't have a lot of preventive health checkups. We're being done. We were under the lockdown. So there was a large group of people in 2020 who did not get their preventive health care. This specifically includes children who would need a lead screening test, or of course vaccinations as well. So I think the message out there that the healthcare organizations are trying to get out, and I know that the medical society is trying to get out there, that it's time, now is the time to do your preventive health care. And we need to emphasize that message to people to make sure you take proactive steps to obtain care. I think that's all I had to share.
Thanks. Really appreciate, John, the work that you and Andrew in HHS are doing to keep track of this. I mean, you're certainly illustrating that we run a few months behind with the data. And that's something we need to just continue to remind ourselves and the public that we're always lagging because we need to collect it, report it, and have the kind of analysis you just provided. I gotta say, I did my preventive health care via telehealth consult during maybe that month even. And it was one of the most thorough examinations I've ever had. I did do my tests in hospital, but the ability to talk about that without having to go through weight room procedures that my attending primary care physician had that day specified for telehealth consults. And it was very efficient and probably as thorough as I've ever had. So I want to be an advocate. It's a viable means of delivery, and don't put it off. I see Representative Marsh.
Yes, I wanted to ask a question, if I might. Jonathan, one of the questions we're trying to, Dr. Ballard, one of the questions we're trying to answer is telehealth going to cost the healthcare system more money? And clearly we've shown here the telehealth visits have increased in numbers. But what also would be helpful is what the total claims are doing. So for instance, if we looked at total mental health claims and could see that they had declined during the period, and that decline was partially compensated or more than compensated by telehealth visits, it would give us a completely different picture, particularly as far as how much this is going to cost for the system. My understanding based on local data that I have seen through the local hospital in which I serve as a trustee is that the increase in telemedicine visits is not sufficient to make up for the total number, the decline in overall visits. But we need to see the data.
I agree with you. Again, it's very difficult. I think it was Rachel who earlier said that we don't know what was the pent up demand or the increased demand and need for telehealth over and beyond what the baseline would have been. So it would be hard to do that analysis. Can point to the, and Mr. Donahue could talk to about this, that the Medicaid program did renegotiate Medicaid rates, rate reduction earlier in this year when the actuaries and the MCOs looked at the data. That did happen. So overall, there, for the aspects for the pandemic and the utilization, did allow for that to happen. Going forward, I'd love to connect with you offline to think about how we can do that type of analysis with the data constraints that we do have.
Thank you.
Yeah, Dr. Ballard, thank you. I would like to say, WellSense has supported maintaining telehealth rates at in-office rates because we do find that it increases access for our members, particularly those with transportation issues, and it also does save on transportation issues. But, I think to everyone's point, we continue to have to look at the data and see what is pent up demand. We are actually seeing members who are requesting in-office visits now because they want to be able to be seen face to face. And we do have a number of members who we are encouraging on preventative care because of the availability of telehealth. It does increase access for a number of our members, particularly those with mental and behavioral health needs.
Thank you, David. Anything else for Jonathan before he needs to get off the call? Thank you, John, for your help. Appreciate it. And moving on, we have two other topics and they can be melded together. Dr. Woods, Representative Woods, you asked at the last meeting that we reserve some time for just some open discussion among members. Maybe there's a thought that you have. Sorry to put you on the spot there. To tee up that conversation.
No, I think this is a critical element. One of my co-committee members likes to tease me about my phrase about looking at the 30,000 foot view. But if we look at that a little bit and put it in perspective, I view telemedicine as a normal transition. 150 years ago, my great-grandfather was a self-taught horseback doctor. Now we developed hospitals and people went to the hospital for their care, et cetera. We've transitioned. Now even physicians don't go to the hospital. Oftentimes we have hospitalists. That's sort of the arc of change. In the 60s, a physician at Mass General was in charge of the healthcare at Logan and found it inconvenient when the EMTs would call and say, I think this guy had a heart attack, and said, look, why don't you just somehow send me his EKG and I can look at it instead of me going through the Callahan Tunnel all the time. And it's developed from there. And I think if we look at the 30,000 foot level, that in fact, it's not so much of what we're trying to do, but the fact that it will occur and we're trying to help it occur in the appropriate manner. And it's multidimensional. Reimbursement is the big issue. Access is a big issue. And as the last questions to Dr. Ballard really address what I call global dollars. Yes, we have an increase of telemedicine consults, but does that prevent an emergency room visit? Does that prevent someone, I need to have a visit, but I live 2 hours away. I got to be out of work for half a day. And therefore travel, I lose money. My employer has some downtime in his business because of the extra time away. Those are what I call global dollars that have been saved, that you can't measure just in how many visits you had and what each visit cost. So I would like to look at it as a two-pronged approach to this, that this is something that's, to my mind, long overdue. As people may know, in the mid-90s, I worked with a group that came within a gnat's eyebrow of getting a pilot telemedicine program in the state, and at the last minute didn't come to fruition. But it's number one, it's long overdue, and I really would. I'll stop there. I tend to ramble. My wife says I talk too much, so I just wanted to expand the framework.
Righto. And I think you're teeing up where do we need to go in the future meetings with more focused discussion on the future uses. So folks, if you've got some ideas there, please. Bill, you look like
Yeah, I was about to say, I sent out the updated version of the guidance from CMS on the 1135 waivers, and we need to remember that a lot of this, particularly the audio only, rests on the federal waivers. So we really need to keep our eye on that. And if that changes, that may very well be something that we have to address.
And that waiver, as I recall, Bill, extends out to December 31st of 21, right?
Yes, or to the end of the state of emergency. So we don't really know when it's going to.
If the state of emergency extends beyond December 31.
Yes, at least till the end of the year, it extends. So that means that nothing needs to be done now.
Right. Right.
Senator, this is Ken, and I just wanted to say I found the data presented by Bill and Lindsay very helpful, and I think that as we look towards the future, continuing to focus on data and seeing what the impact of telehealth is and on the breakouts that Bill provided, but also on licensure will be very helpful.
I'll convey that to Lindsay, that we'd be interested in that information.
If I could add just a comment about licensure. We're struggling with the issue of licensure, and our committee, our Health and Human Services Committee, has been bombarded a bit this year with a lot of licensure issues. My sense is if at some point we could maybe interface with a FSMB or the federal state medical boards in terms of looking at state licensures. That may be an avenue that we could would help us across the nation. In a sense, we already have, in a certain sense, national licensure. If I apply to a hospital as an orthopedist, and I'm board certified by the American Board of Medical Specialties through orthopedics, then I basically have a national licensure in a sense. And if and there's a lot of the psychiatrists, or the psychologists have their interstate compacts, and that has to deal with it. It might be interesting to see if the FSMB or the Federation of State Medical Boards have some thoughts on this.
Be nice to be out front for a change.
Yes.
It seems to be an issue that we run into on the mental health side, that there's less standardization and that the requirements can often be an obstacle for folks coming from out of state, and or the additional requirement of, even once you're licensed, then you have to go through a separate credentialing process for insurance companies and or hospitals.
Right.
Ken, you're raising one of the concerns that a lot of us hear through our communities, the community healthcare organizations. And Bill, you touched on the critical workforce shortage that's being experienced. Some of that's attributable to are we as quick to respond to people interested in working in our state. So Lindsay raised this question about temporary licensure replacing the emergency licensing. Have you had discussions with her and either of you as to how well that is going to continue to draw people into the healthcare field in your areas?
I don't know about the draw into the field. I don't really understand fully what all the ramifications would be. I was really surprised at the 22,000 licenses, and I don't know. I have no idea, truthfully, of how much care has been able to be provided that wouldn't have been able to be provided otherwise.
I've not had those conversations either, and likewise was also really surprised by the 22,000. And I was unclear. Were those folks New Hampshire residents? I mean, she talked about people working across state, living or working across state boundaries, but I wasn't clear if that was residents of surrounding states that that were then applying for New Hampshire licensure, or even whether it's folks from non-contiguous states applying for licensure that were then providing telehealth services.
I don't know.
I can reach out to Courtney to see if she could provide some memo on the 22,000 question. That'd be helpful. Clear up that question. Bill?
Sure.
Yeah, Senator, I have to respectfully ask if I may be excused. I have another appointment to get to.
Let me just, and want to respect that, and we're getting towards the end here. Just to check, what would be the next window? We heard that if we've got some changes that might affect legislation, that our input's being sought by sometime by, I assume, first half of September would be the outside date. So just, folks, any advice as to when we might schedule again? People up for a July meeting?
Yep.
That's fine.
We
Yes.
That would be fine.
Yes.
Own? Yeah.
I'm not sure. I think I'm up next to present the FQHC information, data.
Yes.
And I'm happy to do that. I will be away for about a week and a half in July. So.
If you'll send me those dates, I mean, can you tell us now? Are we in the first half or second half?
The week of 4th of July week, and the Monday after that. So it's like July 5th through the 12th. I'll be away.
Yep. All right. Well, that leaves us 13, 14, 15, 16 in that week. I mean, we don't want to climb right on top of your arrival back home, but maybe later in that week we could aim for.
Sure.
Yeah, or the next week would actually be better if that works for everyone else.
Yeah. Going once, twice, folks. I know.
What date's that again?
We'd be looking either in the 17th, 18th, or 21st, 2nd.
I'll be in Maine, but I may be, I'm not sure about, I can't remember whether they have Wi-Fi access there or not. But,
Both weeks, Representative?
Nope, the week of the 12th through the 16th, I'm in town. But it may well be that there's availability where I'm going to be.
I'm sorry, that would be the 15th, 16th. And then the 19th, 20th, you're away.
Correct.
Yeah. Let me try that 15, 16 date, maybe the 16th, to allow for Joan to have another extra day. Friday the 16th, we could aim for the morning.
Okay.
I just am unable to do like 9 a.m. in the morning. I have another appointment I can't change on that day.
10:30.
Yeah, the state health assessment meets from 9:30 to 11:30 on that day, but we could do it not overlapping.
Yep, 1 o'clock on that Friday.
Yep, that would work.
Sounds good.
That works.
Be Friday the 16th, 7:16, 1 p.m. All right. Thank you, Bill. Thank you so much for your preparation.
I'll send,
You've got our appetites whetted for, what's the next reporting date from that Vanguard study? And
oh yeah, okay, we'll, as soon as I know when it's gonna happen, I'll keep you posted. And
Yeah.
I'll send my slides to Jessica. Is that the best way to do this?
That's perfect. Yeah.
Okay, will do.
Thanks
Thank
so
you,
much.
everyone.
And we'll finish off by just, are there other topics that folks are interested in teeing up? Joan, I think the in-home services conversation would be very helpful.
What do you mean by in-home services?
I'm sorry, maybe I'm mischaracterizing the FQA.
I'll be right, yeah, we're representing the community health centers. And I think someone else, maybe Rachel, is going to represent the home health care.
Yeah, I don't, I think I missed the meeting where maybe that date for that presentation was assigned for the home care. So I'm just not sure where I fall in the scheme.
Yeah. You were going to be just after that. And if it makes sense to combine these in the same day, I just don't want to overwhelm us with.
Yeah, I think I could pull off the next meeting after Joan's presentation.
Okay, all right, let's leave it at that. Would you, I'll put you on the spot. What would be the next ideal date for you to make that presentation? And why I'm interested in that is because I think the in-home services just might overlap with the question that Dr. Ballard raised, which is if people are seeking emergency services over the phone and need MAT support, how is that provided? So I'd hate to miss a conversation on in-home.
Right. So as far as a time period, I think in August, I would be okay at probably any time during that time period if you're looking for an exact date. I'm not sure at the moment.
I'm not sending kids to school in August, so no problem. But others may be.
I don't have a vacation planned in August, so.
Yeah, and likewise. So it doesn't look like anybody really balked at an August date there, no?
I'm going to be gone the first 2 weeks in August.
Yeah.
Senator, I will be sending someone off to college, so I'll be off the week of the 17th up through the 25th.
Okay. Well, that took, and interestingly, August has a date in the 30 to 31st that is pre-Labor Day, which I think relative to our objective of trying to do something before mid-September might fit us well. David, is that you're back then?
Yes, sir.
And Rachel, you'd
I'm
be
still here.
available?
Yep.
Representatives, will you both?
I'm here. That's August 31st, you're saying?
Yeah, 31st.
I'm here.
Okay.
I'm here.
Ken, looking good. Mary,
I think so, yeah.
looking good.
Yes.
All right, I'll float that one out there too. Try to nail down and Tuesday better than Monday, 31st. Just to give us,
I would not be available the 31st.
so 30th would be better.
The 30th is a little better. The 27th, was that the Friday, the 27th, no good for folks?
I don't know, David?
The 27th? Yeah, I can do that.
No, I'm good.
I'm available in the morning, but not in the afternoon.
Bill, any overlap with your committee on a Friday the 27th?
I'm just checking, but at this point in time, that looks okay.
All right, I think we've got a winner. The morning of the 27th. All right, sounds good, feasible. Tyler, I saw you're nodding. It's looking okay on your end.
Looks
And
good.
by the way, Tyler, do you want to just say something about the website that you put up for New Hampshire health costs? Is that something that you can frame as useful for this committee's inquiry?
Probably not. It's not so much focused on telemedicine. It is the price transparency website the insurance department put up what is now almost 15 years ago. It has developed over time. We do provide a lot of additional information beyond the prices of healthcare services, including how to use your benefits and common questions about insurance and delivery systems. So in that way, it perhaps relates to telemedicine, but I was just thinking we probably need to enhance that component on the website. But it's something the department's gotten a substantial amount of visibility for, not just locally, but nationally. And so yesterday we did an overview and recorded it. And it's people are welcome to take a look at that. But probably the best thing to do is just go to the website and play around. It's at newhampshirehealthcost.gov, and yeah, let us know what you think.
All right.
Thank you.
Put that into our minutes. And I want to thank Rachel for being with us today. And
So sorry about the last meeting. I don't know what happened, but it never made my calendar.
yeah, not a problem. Me too, because I took some notes knowing that you weren't there, and I just haven't turned it into something that could be useful, which is a disadvantage because Mary's presentation was very helpful, which is why we got to get it up and out so that other people can view it. Like Rachel, we need to make sure that you can view that. Mary, I can't remember if you sent that to me.
I think I did. I'm more than happy to resend if you need it. That's the easiest.
That probably is the easiest, and I'll make sure that at least Jessica has it so that any member who needs it could request it, as well as anybody in the audience who's listening.
Okay, great.
Thank you, Mary. Dr. Shaw, I see you're still there, so that's great. You've made it through Vermont and still on the call.
Thank you.
And if there's no other business, we don't need to go the full 2 hours. Feel like we covered a lot of ground today, so thanks for making yourselves available, and we'll get this schedule out to you pretty quickly. Thank you very much.
Thank you.
Thank you.
Thank you.
We need to do a roll call. I don't know if we need to. Everyone, motion to adjourn made by Representative Marsh, seconded by Ms. Tulk. And all those in favor, are going to be recorded as having said yes. Thank you very much. Have a good day, the rest of your